and welcome you all to this first online lecture of Neurological Physical Therapy. The topic of discussion for today is muscle performance examination. As you are well aware that previously we were discussing motor examination, and as a part of motor examination we have already discussed muscle tone examination and pupil examination, mental status examination, and reflex examination. Today we are going to discuss muscle performance examination. So the learning outcomes for today's lectures will be that by the end of this lecture you should be able to understand different parts of motor examination, including the ones discussed in the previous lectures, and you should be able to differentiate between normal and abnormal synergies, and you should be able to understand and demonstrate these different concepts of motor skill examination and motor performance examination. So first of all, we are going to discuss muscle atrophy. As you are well aware that muscle atrophy is the loss or waste of the muscle fibers, and muscle bulk is reduced in muscle atrophy. So basically we can divide the muscle atrophy in three different types on the basis of the reason behind the atrophy. First of all, there is disuse atrophy. As you can see from its name, it shows disuse. It means that it develops due to lack of muscle use. So this is a kind of atrophy which develops within weeks or within months, means it takes some times to develop. And as a result of this atrophy, there is a significant loss in strength, and there is reduced passive tension of the muscle. And as a result of loss of strength and loss of passive tension, there will be a reduced joint stability. And if there is a reduction in joint stability, ultimately it will lead to posture instability. So you can see an example of disuse atrophy in patients who are having POP for months and months. When the POP is removed, they have a significant loss in muscle bulk. Next type is neurogenic physiotherapy. So you can see neurogenic atrophy in multiple patients, but specifically the neurogenic atrophy you can see in lower motor neuron diseases or neuromotor neuron lesions. Like if the patient is having some wrist drop, you can see the neurogenic atrophy there. So it means that neurogenic atrophy is common in type of paralysis which is not spastic but which is flaccid paralysis. Neurogenic atrophy is common in flaccid paralysis, and the most striking part is that it develops quickly within 2 to 3 weeks. That's why previously I was telling you that flaccid paralysis is considered more dangerous in terms that it leads to significant atrophy and that develops quite quickly. The next type is protein calorie malnutrition. As you all know that if you are malnourished, then the muscles don't have the energy and don't have the nutrients and not have the basic protein structures to maintain its bulk. That's why it leads to atrophy. And the good example is, as you all know, the Ethiopian nation. You see on a daily basis on TV that they are very lean and they almost have no muscle mass on their body. That is another type of muscle atrophy. So, to confirm the muscle atrophy, you have to examine the muscle bulk. The first part is the subjective part, where you will visually inspect the muscle symmetry and shapes, and you will compare and contrast one limb with the other limb. And the next part that can be the objective part, that is the grit measurement, that will confirm your loss of muscle mass, and you can also use these grit measurements as a part of prognosis, and you will see that whether patient is developing more atrophy, whether progressive atrophy is occurring, or there is a stop in the atrophy. So the method of measuring muscle circumference is quite simple. You simply take some bony prominence, like for the lower limb you can take tibial tuberosity, or you can take medial or lateral epicondyles, anything you like, you can take that for measurements, and you will make a mark there, and then you will make a mark on the almost mid of the limb. Like you can here we can see that thigh is used, and so we'll make a mark on the mid of the almost the mid of the thigh, and the distance should be measured, and distance should be same for the both limbs, and then you will mark the same marks on the other limb, and you will measure the circumference, and you can compare. And on the ongoing weeks it will be used as a reference value, and you will use this reference value to see if there is more muscle atrophy or it is reducing. The next concept is strength and power. You must be well aware of the concept what is muscle strength, what is muscle power, and what is muscle endurance. And it is a very familiar concept as you have already studied it in detail in kinesiology. So I will expect you people to answer the difference between muscle strength, power, and endurance in the comments after watching this video. So the opposite to muscle strength is the concept of weakness. So the patient is not having sufficient energy and sufficient strength to develop force and develop sufficient strength. So the weakness can vary from places, which is partial weakness or partial paralysis, to plagia, which is complete absence of muscle strength. So this term plagia is very familiar to you, and the further terms hemiplegia, paraplegia, tetraplegia, quadriplegia, all are uh, explanation of the type of plegia the patient can be having. So I will further like you people to answer what is the difference between hemiplegia, paraplegia, tetraplegia, and quadriplegia, and this will be an indication of your participation in this lecture. So there are further facts and figures I would like to discuss at this point, that in upper motor neuron lesions, means most of the time we can say that is spastic paralysis, the more loss of strength is in the distal extremities, mean your hands will be more affected as compared to your shoulders. And moreover, in stroke patients, they have examined and they have seen that after 2 months, within 2 months of the event, there is almost 50% decrease in the motor units. And you all know what are the motor units are. They are an indication of how much strength a muscle can generate. More recruitment of motor units leads to more strength production. So if there is a loss of motor units, it means that the muscle is unable to produce sufficient strength. And the fact is that there is greater loss of type 2 fibers that are fast twitch fibers. That means that patient will not be able to produce fast movements and perform fast movements, although he can perform a particular activity, but it will be at a lower pace. Fast motions are not possible. Okay, so in the stroke patients, you should always remember that you will find mild strength loss on the normal side too, and this is due to a small percentage, almost 10% of the fibers of the cortical spinal tract that remains uncrossed. Due to these fibers, there will be mild strength loss even on the normal side. Okay, so as we just discussed that in upper motor neuron, more prominent loss is in the distal extremities. Now, in peripheral neuropathy patients, like in diabetic patients, like in Guillain-Barré syndrome patients, there is again more loss of strength in the distal extremity. But the thing is that these two problems are progressive, and the proximal parts of the body will be involved in a progressive manner. And the spectrum you can see opposite to that is in primary muscle disease like myopathy, where the proximal weakness is more common, and shoulder and pelvic girdle are the main areas of the body that are affected. Okay, next, myasthenia gravis. In this, you see decremental strength losses, means the more movement is performed, the strength is reduced gradually. And myasthenia gravis, you are well aware of myasthenia gravis, that is an autoimmune disease where there is a problem as acetylcholine in postsynaptic fibers. Okay, now we come towards the examination of muscle strength and power. So different methods can be used. The most simple methods you have already learned is manual muscle testing. Manual muscle testing can be used to for examination of the muscle strength. Handheld dynamometers. Here you can see a handheld dynamometer. That is a very objective measurement. Okay, manual muscle testing and part are subjective measurement, but the handheld dynamometer is a subjective measure. The subjective measurement can be taken by handheld dynamometer, and another method is isokinetic dynamometer. Now this is the setup which is called isodynamic dynamometer. As you know, you can understand by the time that ISO means same and kinetic mean movements. So this is the machine, this is the apparatus that makes the patient to perform an activity on a similar speed. So as you know that the angle of pull and the muscle tension and length relationship varies in different part of the range. You know that in initial range the angle of pull is different, in mid range angle of pull is different. At the 90-degree there is the angle of pull is such that you can generate maximum strength, and in the last part of the range again the angle of pull is such that the maximum cannot be generated. And you know that outer part of middle range is the most powerful part of your range of motion. So this is the type of the machine that can lead you to generate and justify the speed according to different parts of the range. So you can use any of these methods to check out the different strengths. Okay. There is a problem in neurological patients that the standard methods cannot be used because the patient has paresis or palegia. So it is not possible for the patient to perform the normal standardized movements, and we used to perform in the manual muscle testing because individual isolated joint movements are not possible. So here we have to make some estimation of the strength by the use of active movement that can be used in different performance of functional activities. Like the patient, you can ask the patient to perform shallow knee bends rather than doing the lower limb examination and examining each joint separately. We have to develop a method, and you have to be creative in this, that you can check multiple joints at the same time with the help of certain functional movements. Like shallow knee bends can be used, sit to stand can be used, and if a patient is able to adapt a position from sit to stand, it means that the muscles, especially the extensors, knee extensors, the hip extensors, have the strength of 3 plus, that they are able to hold the full body weight. So in spite of the injured muscle, we have to adapt to such methods to check muscle strength in neurological patients. Next come the concept of muscle endurance and fatigue. You know that endurance is the ability to perform an activity repeatedly over a certain period of time with some maximal effort. And opposite to that is fatigue. Fatigue is tiredness, sense of exhaustion, decreased capacity of physical and mental work at the usual level. Now, I would like to draw your attention towards that this is not only the physical fatigue, it is also the mental fatigue. So, it is very common in neurological patients that physical and mental fatigue is main issue, and especially the patients like multiple sclerosis, the patients with sensory ataxias and with certain sensory losses, they are unable to perform activity on a sustained basis. So fatigue is the main culprit there. So the causes of the fatigue can be excessive activity. That can be a main cause that can lead to fatigue. The causes of the fatigue can be malnutrition. The causes of the fatigue can be cardiorespiratory disturbances. Another cause can be emotional stress, that you are not feeling like and you are not feeling that enthusiastic. And there can be other factors too that are the mainly the neurological factors that can affect muscle endurance. Okay, so now we come to a term that is overwork weakness, which is usually a phenomenon that is observed in neurological patients. A prolonged decrease in absolute strength and endurance due to excessive activity of partially denervated muscles, for example, polio patients. Here you have the problem that if the patient comes to you and you make him exercise or do some physical activity, the patient will be able to perform that activity at that time, but the patient will not be able to get up or recover from the fatigue for next 2 to 3 days. He won't be able to do his normal ADLs for the next 2 to 3 days because the patient cannot recover with ordinary rest. So you have to keep in mind that overall weakness is a problem that you can encounter in neurological patients. Okay, now when we are discussing about fatigue, we will also have to discuss how will you have to examine the fatigue. So the examination of fatigue starts with the initial interview. And fatigue threshold is the level of exercise that cannot be sustained indefinitely. Means that is the threshold, that is the point from where onward patient is too fatigued to continue that exercise. So there are different outcome measurement tools that can be used for the examination of fatigue. The one of that is modified fatigue impact scale. There are specific performance based testing like functional independence measurement scale. There is board scale of rating of perceived exertion that can be used to check the fatigue rate of the patient. So first of all, I would like to show you the modified fatigue impact scale. Okay, the modified fatigue impact scale is basically a scale. It looks like outcome measurement tool that can be used to record the fatigue of the patient in the last 4 weeks. Now, you can say it is based on a Likert scale 0, 1, 2, 3, 4. Patient have to rate from never, really, sometimes, often, almost, and always. It has questions like I have been less alert, I had difficulty paying attention for long periods of time, I have been unable to think clearly, I have been clumsy and uncoordinated, and so. Okay, and now there are certain questions that let you think about mental fatigue. My thinking has been slowed down, so this is showing mental fatigue. So overall, the this outcome here tool is divided into physical subscale, cognitive subscale, and psychosocial subscale, and then there is total MFIS score that is out of 84. So this is an outcome measurement tool that can be used to rate the fatigue level of the patient. And this scale I have already shared it on your classroom app, and you have to fill this scale with some real patient, and it is a part of your project. Okay, now coming towards the back towards the examination of fatigue, and we were discussing about board scale for rating of perceived exertion. Perceived exertion means the patient's self-rating scale, and here you can see that the scale starts from the 6 where there is no exertion, and it ends at the 20 where there is maximum exertion. So patient have now you see that it's not starting from the 1 or 2, it starts from the 6, 7, 8, 9, 10, and there are many digits that are missing. So actually the 6 means 60 beats per minute, 7 means 70 beats per minute. So this rating and these numbers coincide with the heart rate of the patient. So that's why this is not that simple. So you can use this to rate the patient fatigue. Now, fatigue documentation, other than using these outcome measurement tools, you have to document the fatigue of the patient, and fatigue documentation can be used with the activities that result in debilitating fatigue. Like you have to mention the activities that are very difficult for the patient and that are very fatiguing for the patient, very tiring for the patient, and after starting that activity, at what point in time the patient feels the most fatigued, and what is the duration of the activity, and how much time it takes to recover from that fatigue, and is there any assistance our patient needs to perform that activity, and what is the effect of rest periods or rest times, and is there any compensatory strategies adapted by the patients, and what is the impact on quality of life. Okay, so after this, I will like to end this part of the lecture, and the second part of the lecture will be uploaded soon. I have divided this lecture in two parts for your convenience.